Welcome, and thank you for joining us today for our Opioid Documents in Action webinar, a Q&A discussion with Adriane Fugh-Berman and Judy Butler about their article using OIDA. I'm Kevin Hawkins, Program Director for OIDA at Johns Hopkins University, and on behalf of the OIDA team, we're glad you're joining us today. Please note this webinar will be recorded, and links to the recording will be posted on our website and shared to our email list. The Opioid Industry Documents Archive, or OIDA, is a groundbreaking digital archive of more than 8 million documents arising from the opioid industry that advances understanding of the root causes of the epidemic and helps address corporate behavior that is harmful to public health. Winner of the Society of American Archivists Archival Innovator Award, and co-created by the University of California, San Francisco and Johns Hopkins University, the archive serves as a living repository of information that can be used to learn from the opioid epidemic so as to improve and safeguard public policy and public health. OIDA is a public archive created and funded in part through settlements of public interest lawsuits filed by states. Views today expressed by today's presenters do not represent the views of the University of California, San Francisco or Johns Hopkins University. We would like to acknowledge the millions of Americans who have been personally impacted by the crisis, as well as to recognize the attorneys general and many other parties whose vision and commitment to transparency and accountability has made the archive possible. We're developing this digital archive and its supporting resources for the benefit of the public, including individuals, communities, researchers, journalists, policymakers, and others affected by the crisis. OIDA and its services are freely available to all. We strive to ensure that OIDA serves as a trusted source of information to help people understand the U.S. opioid crisis. Indeed, there are many stories to tell from the OIDA documents, from marketing tactics to abatement strategies to policymaking, and much more. We expect the archive to support research looking back at the crisis and helping to formulate systemic change to prevent future harms to public health. To that end, the OIDA team is creating a number of resources to help with further exploration, teaching, and mining the archive. For example, we've recently introduced an opioid crisis timeline, a curriculum library, the OIDA data toolbox, the OIDA image collection, and a redesigned website. These resources provide archive visitors with footholds and tools for research, data analysis, and other forms of exploration and discovery. I now want to introduce Dr. Michael Steinman, professor in the UCSF Division of Geriatrics and at the San Francisco VA Medical Center, who will introduce our speakers and moderate today's discussion.
Great. Thank you, Kevin. And I'm really happy to and delighted to introduce our speakers today. Dr. Adriane Fugh-Berman and Dr. Judy Butler. So Dr. Fugh-Berman is a professor in the Department of Professor of Pharmacology and Physiology with a joint appointment in the Department of Family Medicine at Georgetown University Medical Center. Dr. Fugh-Berman directs PharmedOut, a research and education project at the Georgetown University Medical Center that promotes rational prescribing, exposes the effect of pharmaceutical marketing on prescribing practices, and has had a profound impact on prescribers' perceptions of the adverse consequences of industry marketing. Dr. Fugh-Berman has authored many key articles and peer-reviewed literature on the area of industry influence on medicine, including the first studies in the medical literature about how the pharmaceutical industry influences surgeons, pharmacists, basic scientists, and individual patients. Dr. Fugh-Berman graduated from Georgetown University School of Medicine and completed a family medicine internship in the Residency Program in social medicine at Montefiore Hospital in the Bronx. Judy Butler, MS, is the Senior Research Fellow at PharmedOut. Ms. Butler has authored several peer-reviewed articles, including articles on opioid marketing and consumer advocacy groups. From 2018 to 2024, she authored columns in the PharmedOut monthly newsletter. Her previous work exposing tobacco industry marketing strategies informs her understanding of pharmaceutical industry practices. And now I'm honored and delighted to turn it over to our speakers so they can share a short presentation about their publications.
Thank you so much. Thanks for that lovely introduction, Dr. Steinman, and thanks so much to OIDA as well. Our conflict of interest statement is that I'm a paid expert witness in litigation regarding pharmaceutical marketing practices, including opioid marketing. And both Judy Butler and I are unpaid advisory board members for Physicians for Responsible Opioid Prescribing. There's been a lot of research on opioid promotion through advertising and drug reps, but in our paper, we focused on covert marketing. So the way that pharma influences what doctors believe not only about drugs, but also diseases. So covert marketing is the way that industry secretly plants marketing messages into continuing medical education and articles in medical journals, prescribing guidelines, and all kinds of places. And because companies want to hide what they're doing, documents disclosed in litigation are one of the few ways that we can actually see how they do it. Next slide, please. This slide is from OIDA, and it shows that industry considers continuing medical education marketing. You can see that CME programs and CME websites are under marketing. The FDA doesn't consider CME marketing, they consider it education, but it is actually marketing. And we're very grateful to the Opioid Industry Documents Archive for help giving us the inside scoop on what industry doesn't want anyone to see. And what we see in these documents is that industry pitched opioids as this appropriate, safe, effective treatment for what was supposedly an epidemic of undertreated chronic pain. These marketing messages were repeated over and over again by people and organizations that were paid by opioid manufacturers. The marketing messages also came from what industry calls key opinion leaders, who are prominent doctors, usually nationally known, who are paid by industry, and they influence doctors in a lot of different ways. So this is a list of the different things that KOLs do. And in this case, the condition that KOLs were increasing awareness of was this supposed epidemic of chronic pain. And they expanded the population that was eligible for treatment by promoting inappropriate use of opioids for people with non-cancer chronic pain. And so beyond cancer pain to patients who had arthritis or patients who had back pain. And then they also changed perceptions about adverse effects by underplaying the risk of addiction. Marketing messages permeate medicine. After a while, even people who have no financial ties to industry cite marketing messages because they cite them as fact because they hear these messages everywhere they turn. And PharmedOut has pioneered research that reverse engineers current marketing messages from industry-sponsored continuing medical education or medical journal articles. We use those techniques as well as documents from OIDA to look at how industry created 4 medical terms that became widely accepted, but were actually marketing messages designed to encourage overprescribing of opioids. The 4 terms are opiophobia, pseudo-addiction, breakthrough pain, and pain is the 5th vital sign. And now I'm going to turn it over to Judy Butler to go into detail about these 4 terms.
Thanks, Adriane. I'll start with the oldest, opiophobia. Next slide. Opiophobia was coined in 1981 at a PharmedOut conference. That was about the same time the New England Journal published Porter and Jick's letter saying that patients on opioids didn't become addicted. Doctors were told they had opiophobia if they were cautious about prescribing opioids because they were concerned about addiction. Opiophobia told doctors that their caution was an irrational fear, and doctors were told their phobia was actually hurting patients. Next slide. They were making their patients suffer from pain that could be treated with opioids. It was a shorthand way to make doctors question their training. KOLs were using this term to imply doctors were ignorant about opioids, and that was why pain was being undertreated. In fact, doctors were exactly right. Prescribing opioids can lead to addiction. Next slide. The term was so absurd that it even made people working for opioid companies laugh when they noticed it in marketing plans. Next slide. That brings us to the second term, pseudo-addiction. Of course, doctors who prescribe more opioids did start to see patients become addicted. So in response, the industry created another term to explain away what the doctors were seeing. If a patient was being treated with opioids and they started showing signs of addiction, say watching the clock for their next dose or doctor shopping, then the industry message to doctors was that that behavior isn't actually addiction, it's just pseudo-addiction. They told doctors to doubt their own judgment when their patients were becoming addicted. And they built a great marketing strategy into the term because, by definition, a patient with pseudo-addiction is not getting enough opioids for their pain. So the way to cure pseudo-addiction is more opioids. Next slide. As opioid use grew into an epidemic, Purdue doubled down on pseudo-addiction. Their guides on preventing abuse didn't look like advertising, but they were filled with marketing messages and misinformation. They taught doctors to recognize addicts by looking for physical signs of abuse, like track marks or a perforated septum. Although they cautioned that even then, opioid use might not be a problem. In contrast, they reassured doctors, falsely, that someone with pseudo-addiction may show behavioral signs of addiction, but they're just seeking pain relief, and they need more opioids. KOL simply told doctors that if a pain patient was seeking more opioids, the first step should be to increase the dose. And just like opiophobia, pseudo-addiction started showing up in medical journals. A 2014 review found more than 200 articles mentioned pseudo-addiction. A few were critical, but most, including clinical reviews and guidelines telling doctors how to prescribe opioids, presented pseudo-addiction as an established fact. No evidence needed or offered. Next slide. A third concept created by industry with no evidence was pain as the fifth vital sign. The industry-funded American Pain Society introduced the idea, but it was actually a highly successful Purdue marketing campaign. Every few hours, nurses in the hospital check a patient's condition by measuring the 4 vital signs: pulse, respiration, blood pressure, and temperature. The campaign proposed that they should also check pain. That meant every vitals check would be an opportunity to consider opioids. But pain isn't a vital sign, and there's no objective way to measure it. Next slide. Nevertheless, the Veterans Administration adopted pain as the 5th vital sign, telling VA health professionals to check pain regularly and to always treat it when they find it. The accrediting organization that oversees hospitals in the US, you may have seen it on the last slide, required all hospitals to screen for pain, and patient ratings on whether a hospital had done everything possible to manage their pain were factored into a hospital's assessment. Low scores from patients meant poor ratings, and hospitals with poor ratings got less federal reimbursement. So to keep patient ratings high, hospital administrators pushed doctors to prescribe opioids. Next slide. The objective of the 5th vital sign campaign, that any pain should always be treated, had an impact beyond hospitals. State medical boards, they're the organizations that can sanction doctors for misprescribing, were adopting guidelines that actually promoted opioids for pain. The change in state policy was driven by opioid companies. They were funding the national organization of these boards, the Federation of State Medical Boards, or FSMB. FSMB released model guidelines written by a committee of industry-funded pain groups and then encouraged states to adopt them. The model guidelines said doctors wouldn't be sanctioned for using opioids to treat pain, no matter how high the dose. And they could use opioids even if there's a history of substance abuse. In other words, doctors should never worry about being disciplined for prescribing opioids for pain. But FSMB and industry found a way to make sanctions work in their favor a few years later. A new model policy did threaten doctors with sanctions for under-prescribing opioids. FSMB got that message out to doctors too. They sent a prescribing handbook, funded and co-written by Purdue, to every doctor in the US. And then they promoted an online CME course based on the handbook. The first 3 terms, pain as the 5th vital sign, opiophobia, and pseudo-addiction, were all invented to make doctors believe opioid addiction wasn't a problem when treating pain. And these terms were used in lectures and CME and medical journals to convince doctors that instead of worrying about addiction, they should be focused on pain. And opioids were the gold standard for pain. The 4th industry term we looked at did that too, but it also became a diagnosis that created a market for a new type of opioid. Next slide. Before companies were selling extended release opioids like OxyContin, the term breakthrough pain had been used for patients so severely ill with cancer, they took opioids around the clock. If pain broke through between doses, doctors would give the next dose sooner. But a KOL turned breakthrough pain into its own diagnosis by publishing a paper that defined it and called for a specialized treatment, a fast-acting opioid with a short half-life. Not surprisingly, that's exactly what companies had in development: fentanyl products that were absorbed transmucosally, like chewing tobacco. The business challenge was that there weren't many uses for these opioids. They only lasted about 45 minutes. Breakthrough pain, a different type of pain that justified a different type of opioid, was just what they needed to market their product. Their strategy worked. The first opioid approved specifically for breakthrough pain in cancer patients was a fentanyl lollipop, Actique. Next slide. Although it was only approved for cancer patients, Actique was illegally marketed for any patient on continuous opioids. Pain is pain was the campaign slogan. For example, a CME taught that any patient on around-the-clock opioids, whether for cancer or low back pain, could have breakthrough pain. And the best treatment? New fentanyl products. Next slide. When this article based on the CME was published, those messages became part of the medical literature. The breakthrough pain concept convinced doctors to prescribe more opioids that were even more addictive to patients who were already taking around-the-clock opioids, and that increased the risk for both addiction and overdose. Next slide. These were new terms invented by opioid companies, but the companies also redefined existing terms like tolerance and dependence. Industry reframed tolerance and dependence as normal adaptive states. They're not. They're really warning signs of substance abuse. Next slide. Look at how KOLs were training doctors. They said that when patients taking opioids feel pain, doctors should increase the dose to decrease the pain. There's no dose that's too high. What they didn't say was that people may become tolerant to the pain-killing effects of opioids, but they don't get tolerant to the harms.
Language is important. Drug companies don't just sell drugs. They sell concepts of disease, and industry uses KOLs, medical publications, CME, and medical societies as mouthpieces for marketing messages that don't look like marketing. In this case, they used language to normalize inappropriate prescribing of opioids and to convince physicians that addiction wasn't really addiction. When industry invents diseases and redefines medical terms, patients may be harmed. Next slide. This is an ancient history. In 2023, just a few years ago, our co-author, Aiden Kaspari, was taught about pseudo-addiction at Nova Southeastern Medical School in Florida. It's a great example of how pharma language outlasts marketing campaigns and continues to affect medical perspectives for decades. We need more research on the extent to which pharma has tainted medical knowledge, and we need to take action to prevent pharma from continuing to do so. It's vital to separate pharma from medical education. Thank you very much.
All right, terrific. Thank you for such an informative and interesting presentation. So the Q&A chat feature is open, so we strongly encourage those in the audience who have questions for our panelists to please put them there. But to start us off, I'll kind of kick off with one question. And that is, can you talk about how industry made a distinction between legitimate pain patients and abusers? You touched on it some in your earlier comments, but I'm wondering if you can expand on that idea.
Sure. Yeah, it was really key to sort of to separate. And this was actually a marketing strategy of Purdue to separate what they called legitimate pain patients from abusers. So the concept of pseudo addiction made physicians comfortable with increasing opioid doses and increasing opioid doses in patients who were clearly having signs of addiction, which then was termed pseudo addiction. But at some point, when physicians got really uncomfortable, they would jettison patients and they would say, well, they're abusing. This patient is clearly addicted and they're they're abusing the drug. So this was really unfair. These were all addicted patients, but separating them into the legitimate pain patients, the good patients, and then the abusers who are like the bad people, made physicians comfortable with both increasing doses of medications, but also getting rid of patients when they became uncomfortable. And that was actually a tactic that was proposed at Purdue to make that separation, that artificial separation.
Terrific. Judy, anything to add to that? Great. Well, we have our first question in the chat. Thank you, from Kevin Kingma. Has this opiate misadventure affected the concept of key opinion leaders, or KOLs?
No, they're still widely used. Pharmaceutical companies still use KOLs in everything. They've sort of expanded it now. So now there's also, it's not just well-known physicians, but it's also physicians who have a big social media following. So there's digital opinion leaders and connected opinion leaders, and even and patient opinion leaders as well. So they've expanded the concept, but KOLs are still widely used to promote a wide variety of drugs and diseases.
Terrific. Thank you. There's another question which I'm going to paraphrase here. So there's non-opioid medications have their own risks. And I was wondering if, how you were thinking about and what you saw in the literature about the reflection about the benefit harm of non-opioid pain medications as opposed to opioids, and how that was reflected in marketing.
Yes, it's really interesting because there actually was a lot of exaggeration of the adverse effects of, for example, nonsteroidal anti-inflammatory drugs that was done by opioid manufacturers. So they, for example, said that NSAIDs caused a huge number of cases of bleeding, and it turns out that was a really misleading that was a really misleading characterization. And certainly, the NSAIDs can cause bleeding. They can cause other problems. Acetaminophen can absolutely cause liver problems, but the incidence of serious adverse effects is much higher with opioids. And sometimes combining things can be sort of a magic solution. So actually, like combining acetaminophen, which is a fairly weak painkiller, with nonsteroidal anti-inflammatory drugs, has a really a great synergistic effect that can be as strong as opioids, even for some types of acute pain.
Right. The next question relates to product monographs, and I'm curious, those are regulated by the FDA, and did you find any evidence about how industry might have affected the content of product monographs so that their contents could be perhaps used for promotion and marketing as opposed to an objective discussion of risks and benefits of the drug?
Are we talking about the product labels?
Yeah, like the very long list of benefits and harms that comes with each medication.
Yes,
And particularly like the concept that addiction, I don't know if the concept that addiction is rare actually made into those monographs, but the questioner sort of implies that it is. I'm curious if you looked into that at all, have any information on that.
Yes, the language in product inserts is negotiated between the FDA and drug companies. The FDA can inflict a black box warning, but the language otherwise is negotiated between the drug company and the FDA, and so that's one reason why they're so hard to read. And there's a great example of there's an opioid called tramadol, which a lot of physicians and patients don't know is actually an opioid. But that was originally there was information in the labeling that had been put there by the company that about the lack of addictive potential that was extremely misleading, and it was eventually taken out of the label. So yeah, it was when tramadol was first on the market, it was not regulated as an opioid. Actually, it still is not. It's still, we finally have we finally have upgraded. It's at least it's in the category of addicted substances, but it's still not regulated in the same way as other opioids.
Thank you. There's a question about changing language that names a particular company, but I'm curious in general if in your work you have found like these same problems that you described for opioids applying to either other opioid medications which were not represented in the OIDA documents, and also other drugs outside of the opioid space where these same issues about kind of medicalization of normality and sort of creating new terms to drive decision making has flourished.
Yes, absolutely. And in the opioid area, there's a medication that's used to treat opioid use disorder, buprenorphine, Suboxone, and there was a form of Suboxone that was definitely over promoted, and there are many other examples in other areas as well, where pharmaceutical companies they're changing concepts of diseases, or in some cases even just inventing diseases in order to position a particular targeted drug. So there are many examples outside of the opioid area for sure.
Right. There's a question about sort of generic manufacturers. So traditionally, generic manufacturers have had less financial incentive to promote medications just because their payout is so much less than drugs that are on patent. But I'm curious what you see either, in probably not represented in the OIDA documents, but in other work about the role of generic manufacturers in promulgating marketing messages, and also what their responsibility is to maybe counter or otherwise rationalize information that might have come from the drugs originator.
Yeah, I can't say I know a lot about the contribution of generic manufacturers. Certainly, it's less advantageous to them to or even to branded drug manufacturers. It's a different situation when they have generic competition going on at the same time. And there's certainly lots of things that pharmaceutical companies do, that branded manufacturers do to eliminate generic competition or to delay the entry of generics into the market. But yeah, other than that, I don't know very much about that.
Okay. The next question from Marc-Andre Gagnon has an interesting question. I mean, you kind of touched on before, but I was wondering if you might care to expand on it. Whether we have like we're like the drunk under the streetlight issue, where we have the documents, so that's where we look. But there's this whole other universe where we don't have documents. So I'm curious if you have any insight whether the promotional strategies used by Purdue Pharma that you outlined in your paper, are they worse or more exaggerated than ongoing strategies used by other drug companies for other types of products? Or is this more likely to be an equally widespread and problematic phenomena that applies across a whole wide series of drugs and manufacturers?
Yeah, great question. So the promotional strategies, the use of KOL, the use of continuing medical education, very important marketing strategy. And the other strategies are common among other drug companies promoting other drugs as well. In the case of opioids, we could argue that the effects were much worse. That the opioid epidemic, the epidemic of overdose and the epidemic of addiction and other adverse effects as well was particularly bad. But the promotional strategies definitely are used by other companies. There were some things that were a little different among opioid manufacturers. For example, at some point, Purdue is actually paying drug reps for the increase in sales of any opioid medications in their territory, and just I guess on the grounds that if somebody started to take opioids, they would keep taking opioids, and that would still result in market share for them. But that seemed quite unusual to me, that they would actually be their bonus structure actually included any sales of opioids in a drug reps area.
I have another question I'd like to kind of follow up on that. As you were talking, I was kind of thinking about the role of key opinion leaders. And I would suppose that most key opinion leaders, either individuals, but also organizations you mentioned, like the VA and JACO, which, most of those organizations and people were likely trying to act in the best interest as patients in science, and yet somehow got co-opted into promoting these marketing messages. So I'm curious if you found in your research or your prior scholarship any information about how how key opinion leaders who were presumably acting what they thought was the best interest of patients were sort of influenced by those messages and end up promulgating them on to other frontline clinicians.
Yeah, that's so great. And I'm going to divide that into two parts because, they're also getting in with government, right? Like they're affecting the FDA, they
Yeah.
affect HHS, they create these public-private partnerships, right? And so there's this concept that it's good for a government to work with industry, as something I think that could definitely be questioned. And the key opinion leaders, like we talk to many key opinion leaders. Often the key opinion leaders don't even know the message that they're conveying for a company. And marketing for a drug can start 7 to 10 years before a drug even comes on the market. Like the drug may still be in animal studies, but the company is still planning what publications it's going to put out there, what messages it's going to put out. So there's usually about 15 to 20 marketing messages that are attached to each drug. And some of those marketing messages have nothing to do with the drug itself. It might be about promoting promoting the disease, for example. And so a key opinion and the high up people in a drug company will go and talk to up and coming academics who are publishing a lot in a particular area in a university, and just take them out to dinner and talk to them about their research. And if what that academic is saying aligns with their, if the academic says a particular disease they think is, the most important thing, I don't know, undertreated chronic pain is like the worst scourge of humanity or whatever, maybe that's really what that academic believes, then they're going to be flown around by that drug company. They're going to be used by that. They're going to have articles, written or co-written by the drug company, and they'll get all kinds of support from that drug company. And if a doctor is saying that they think drugs are overused and people should exercise more or whatever, they'll get a nice dinner, but they're not going to be flown around to conferences. And so then over time, you end up having these key opinion leaders with specific marketing messages that they may not even be aware are marketing messages for a company whose opinions dominate medical discourse.
Terrific. Thank you. The question from Joel Lexgen: why do you think that the marketing campaigns seem to have been much more influential in the US and to a lesser extent in Canada, but seem to have had not have the same impact on prescribing behavior in other countries?
Well, of course, in the US, we pay more for drugs than anywhere and than anywhere else, are definitely targeted more. And because we have such such an inefficient and diverse patchwork of healthcare systems and healthcare provision, and we don't have we have very limited government control of drug prices. This is the most profitable place to push drugs. And it would be interesting to look at it also if there might be some cultural differences among countries as well. But I think most of it is probably the financial the way the finances are set up. Drugs cost more here, and we don't have the same kind of government controls that countries with rational healthcare systems have.
Fair enough. Yeah. There's a question from Lindsay Marshall, maybe paraphrase. She asks, I'm curious how deploying terms like disease was mobilized to increase support for increasing opioid availability and access, but maybe the concept of disease was de-emphasized for issues like addiction and addiction treatment, and how this sort of language around disease, what's disease and what's not disease, sort of flowed in these opposite sides of the spectrum.
Yeah, that's so interesting. That concept of, yeah, what is disease and what is chronic pain a disease? Is a symptom a disease? Is a collection of symptoms a disease? And who decides what's a disease and what isn't a disease? There have been a number of diseases that have just been created by industry, including hypoactive sexual desire disorder, the daughter of the also invented female sexual dysfunction, binge eating disorder as a separate disease was invented by drug companies, osteopenia. I mean, there's a long list of social anxiety disorder. So there's really a long list of things that weren't considered diseases until industry decided to make them into diseases and convince physicians they were diseases. So yeah, really interesting because everything's different um, once you term something a disease.
Perfect. Um, the next question addresses kind of the contemporaneous nature of the documents, and obviously a lot of these documents are now, decades old. And I'm curious if you can provide any insight or thoughts as to the applicability of what we know from these documents, which are now sort of came from the past, to current marketing practices.
Yes, of course, drug companies always want to say like, "Oh, those were the bad old days. Everything's different now," because just by the nature of the slowness by which legal proceedings happen, by the time documents become available in OIDA, they're going to be older, right? But we know because we farmed out. Works with some industry insiders. So we do know that many of these tactics are still going on in the same way, or sometimes in slightly in modernized ways. But that's also we've been trying to sort of create techniques for reverse engineering marketing messages in real time. So since we know that there's 15 to 20 marketing messages for every drug when it comes on the market, we've sometimes like watched or forced students to watch, dozens of continuing medical education activities or to read dozens of articles in the medical literature and pursue particular what is everything that this key opinion leader has said about this drug, and you start to see these themes, the same things being said over and over again. And I think like a great example is one of our students was putting together clips that were from different continuing medical education modules on opioids in which they were trying to normalize people taking higher and higher doses of opioids, right? So normalizing dependence, normalizing tolerance. And so speaker after speaker in these opioid manufacturer funded continuing medical education modules said, it's like a hot shower. When you first get into a hot shower, we're like, whoa, this really feels hot. And after a few minutes, you find yourself turning up the hot water, don't you? Well, no one says you're addicted to hot water, do they? And that same line was used by different people in different KOLs in different continuing medical education modules. And you can see how sort of, it's almost a hypnotic message. Like, yeah, no, I get that about a hot shower. So maybe it is okay to just keep increasing the dose of opioids among my patients.
Well, I'm in California, so we kind of try to restrict our showers for water usage. So it may not work as well here, but I get the point. A question from one of the audience members kind of concerns the company Invidior, which I guess used to be Reckitt. And I was wondering if you found any information about that particular company and their marketing messages that you care to comment on.
So we haven't done much on that in FarmedOut. Gail Grove Scott is a whistleblower who's done quite a bit of work on over promotion of some of Reckitt and Divior's products. I mean, they definitely over promoted and misleadingly promoted Suboxone film, for example, in the way that they promoted Suboxone, that's buprenorphine. It's a treatment along with methadone for opioid use disorder. And there were definitely ways that they over promoted it. So they also did bad things.
Thank you. I was curious if any of the documents talked about the role of partial opioid agonists like buprenorphine, which can be useful for the treatment of opioid use disorder, and how that kind of came in along with the pure opioid agonists.
I'm sorry, I didn't catch the beginning of the
Oh,
question.
I was curious if there was anything you found in the documents about marketing of medications used for opioid use disorder like buprenorphine, and in addition to marketing for sort of the pure opioids.
Oh, I see. That's not really what we were looking at, but Judy, did we find, and we weren't, yeah. But we didn't find that, but we weren't specifically looking at that. So it's a different opioid treatment of opioid use disorder is very different than treatment of chronic pain.
There's an interesting question about the use of kind of racialization of pain and addiction. And particularly, the questioner asks about how white, middle, and working class individuals were originally a target population, with the positing that drugs like buprenorphine were kind of now sort of, made to normalize as like the new suburban person, not like the hardcore addict, and how the concept of opioid addiction was kind of framed in racial, ethnic, or socioeconomic terms.
Yeah, there's really very interesting aspects of race and racism around this, and um, there's some there may have been actually less over promotion of there may have been less over prescription of opioids in the Black population because doctors may have been more suspicious of Black patients because of racism. That anyway, that's one aspect, but there's also this racial there is methadone is used more in poor populations, buprenorphine more in higher SES socioeconomic status populations. There's a lot of really interesting questions around race and the provision of medications for pain and for opioid use disorder and for many other things as well.
Thank you. There's an interesting question about your research methods. So you have this vast trove of documents that you're trying to go through, and you can talk a little bit about how you approach the process of reviewing those documents and synthesizing those messages.
Yeah, so we were more using social science a methodology to look at continuing medical education modules, and we've done several papers on this. So this particular one, and Judy, help me out here if we're talking about this specific paper, but we looked at a variety of different materials. So we were both looking at we didn't limit what we were looking at to what was in the documents that had been exposed in litigation, but we also looked at articles in the medical literature and at continuing medical education activities. Sometimes we've done so some of our work is sometimes like focused only on CME or only on articles in the medical literature. I think for this one we looked more broadly.
Yeah, we definitely looked more broadly. And we also found OIDA particularly helpful if we had found something referenced in an article, but we didn't actually have the original document. So we could go back and just look for that particular document in OIDA, and chances are it was there and you could see what they were doing. And then from there, you could go beyond that and search within OIDA for what was happening around the development of that document. So that was very helpful.
Thank you. There's a few questions that kind of touch on the issue of untreated chronic pain. I think we all agree that, pain is bad and we want to help people to, reduce their pain. And of course, we want to avoid the harms that come with pain treatment. And I'm curious how you sort of think moving ahead, we can optimize appropriate approaches to pain to help patients and people, with their real needs while avoiding the potential harms of over-marketing and harmful misuse of opioids in a way that ends up causing more harm than good. And how you think that, you know, that government and policymakers should be promulgating messages to hit that optimal sweet spot.
Yeah, really interesting issues because of course, I think it's really important to say that there's an appropriate use for opioids, that opioids are really important for end-of-life care. They're really important for cancer-related pain. They're really important for acute pain, although there's more and more research coming out that you don't always have to use opioids for acute pain, and that a combination of NSAIDs and acetaminophen can be as effective as opioids, even in things like kidney stone pain, which is horribly painful. So, and the best way to prevent chronic use of opioids is minimizing acute use of opioids. Many people who start off using opioids for a sprained ankle or something like that will end up staying on opioids later. So we really want to be judicious about when we're using opioids for acute situations, but there are for end of life care, palliative care, cancer related pain that can be really useful. But the problem of chronic pain is a terrible problem, and it's very different than acute pain. The treatments that work for acute pain don't work for chronic pain. Opioids can actually cause hyperalgesia or increased pain over time, that sometimes people's pain actually gets better when you back down on the opioids when someone's on chronic opioids, or they're not the best treatment for chronic pain. But we need a lot more research into chronic pain. It's quite different. It ends up sort of there's almost a sort of a rewiring of the nervous system that happens in chronic pain that needs to be dealt with very differently. And it's a very understudied area. So we need a lot more research in that area, but opioids are not the answer.
Michael, we can't hear you.
Thank you. Sorry. There's a series of questions that have been in video that I prefer not to get into individually, but they sort of recapitulate the theme of concern about ongoing marketing and harm that Invidior and its predecessors have caused. And you commented on that earlier, and I just wanted to ask if you had anything else to sort of share about that. I know there's limited what you can say based on the research you did, but anything else you want to comment about that particular drug because it does seem to be, or company because it does seem to be of interest, particularly on Suboxone.
Yeah, I mean, I've already said some things about about Suboxone being over promoted in some circumstances, but that's not something that I've studied in depth.
Great, thank you. There's a question that just came in about how do you see countering the role of drug companies? I'm sorry, let me say. I'll read the whole question to make sure I get it right. The way that Purdue and other companies control knowledge about opioids is not unique, as you've mentioned earlier. Drug companies are no longer just selling products, but they're selling knowledge, as you have mentioned. How do you see countering the role that drug companies have in the way that knowledge is developed and distributed? You talked about this some before, but anything else to comment about how to combat problematic marketing messages?
Yeah. I mean, they're really we shouldn't be allowing industry supported continuing medical education. I mean, pharmaceutical companies should not be involved in any education of medical students, residents, or attending physicians. They're extremely good at messaging and psychologic manipulation, and of course, they're not going to be providing objective information about their drugs or competing drugs, but we need to get them out of medical education. Like that's really, that's really a key thing. And we're currently doing a series of grand rounds lectures, talking to doctors about ways that they can avoid industry influence, including not going to industry dinners, not taking drug samples, not doing industry funded continuing medical education, not seeing drug reps. But there's so much there's so much influence on medical literature and medical meetings. Like why are professional societies allowing sponsorship of pharmaceutical companies at their meetings? It affects who's speaking at those meetings and what perspectives are being put forth, and how much discussion there is of diet and exercise and generic drugs and um, um, alternative therapies. Like it affects what people are actually discussing in medical meetings and in the medical literature. And we need to take back our profession and not allow pharmaceutical companies to be setting the agenda for medical knowledge.
And to follow up on that, to the extent to which marketing messages have penetrated and the new concepts of what's a disease or new terms that people are using to kind of help to push them towards certain prescribing behaviors, what are ways that we as a profession and the larger community can help to sort of counter those messages that have already been promulgated and kind of reverse the use of language that ends up being potentially misleading or causing more harm than good?
Yeah, that's so great. Grand rounds at academic medical centers and in community hospitals, like that used to be, grand rounds used to be when someone presented an interesting patient and people, um, and doctors and medical students like sort of studied together and taught each other about things. And now it's always someone from out of town with slides. Often many people who are paid by pharmaceutical companies, because they'll often fund meals at grand rounds, they'll fund grand round series, that kind of thing. A part of what we're fighting. But there are programs in which grand rounds are held in a small program. They're held in attendings' homes, and the attending has to like provide dinner for the residents. Or, they cannot. I love that idea.
Yeah.
Or the program itself could be providing food and a place for people to actually like do the research themselves and to learn on their own. Like that gives us a chance of having objective information, but like doing our own research, relying on non-industry funded publications and people and meetings is key.
There's a question about medical devices. I'm curious if you have any insights into how some of these messages or the themes which you've elaborated on might apply to medical device advertising.
Yeah, it's very similar and very different. Medical devices are much less regulated than drugs. Implanted medical devices can be approved without ever having been actually tested in humans. And medical device salespeople are often in the operating room with physicians, and are considered part of the operating team. That's a major problem, and it's actually something that we've done several articles about that are on our website, and we're continuing to do work on that. So the way that medical devices are promoted is not it's not in the same way. Like medical device reps deride drug reps as, oh, they're caterers, because the medical device reps don't bring lunch. They provide services, in the operating room. So it's a very different way of marketing, but is extremely effective and definitely has an effect on public health.
We're also seeing with the kinds of medical devices that physicians can give out in primary care offices. When Adriane was doing grand rounds, some of the hospitals would say, or the practices would say, we don't allow drug reps in our offices to give us samples, but we do take samples of medical devices. So that was interesting as a difference between the two.
Interesting. And I'll say perhaps what made the longest answer for last, even though I'm going to ask you to save your comment for about 30 seconds because we have to finish up. AI, and how do you perceive the role of AI moving forward in terms of what's the content of AI responses that are generated and how we can avoid having drug company influence kind of removed from prompts for answers to clinical questions?
Well, they're already all over electronic medical records, and you know, the what drugs come up first as suggestions when people are doing e-prescribing and stuff is very affected by pharmaceutical companies. They also are all over Doximity and Open Evidence, which are used by most of the doctors in the United States. Yes, they are already there, and we're just starting. We're just starting to look into that.
Terrific. Well, thank you for such a thoughtful presentation and answers to the many great questions we got. And let me turn it back to Kevin.
Thank you. I want to reiterate that that was a really great discussion. Appreciate everyone who contributed to it here. We're about to conclude the event, so please don't hesitate to follow the links on the screen or in the chat to connect with us about using OIDA. We hope to see you all at future OIDA events. Webinar registrants will receive event announcements from our OIDA email list, so we'll be subscribing everyone who joined today's webinar. So thank you again to everyone for joining us today.
Thank you.